Hello, my name is Katrin Pucknat. I'm the president of ResMed in Germany, and I would like to share a few thoughts around digitalization in healthcare with you today. ResMed is a global leader in tech-driven digital solutions for patients with chronic lung disease such as COPD and sleep apnea. In Germany alone, over 25 million people suffer from these diseases. We are driven by digital innovation. Globally, over 12 million patients actively use our cloud-based technologies every day and night. In Germany, over 100,000 patients are already digitally supported by physicians and medical professionals and achieve better therapy outcomes and higher patient satisfaction with our technologies. We are passionate about leading the way in cloud-connected medical solutions that enable patients to live healthier lives. We welcome the pursuit of the German government to set a new standard in digitalization of healthcare. Why is this so important? A McKinsey study from 2018 proposed that sensible digitalization of the German healthcare system may lead to annual cost savings of up to 34 billion euros. This is a substantial amount, considering the potential budget shortages of the future. However, what would sensible digitalization look like? Digitalization not only includes the introduction of electronic health records or electronic prescriptions. We have to align our health system and its structures so that we are able to take advantage of the opportunities of digitalization. It does not only require a change in IT and infrastructure, it requires a complete change of mindset on how we go about healthcare. To achieve successful transformation, we must shift our focus away from individual disease episodes and events to holistic view and management of the health of each patient. What is today a disease-oriented system must evolve into a true healthcare system. And this requires us to design healthcare without barriers and remove sectoral thinking and siloed processes. Technology represents a massive opportunity to deliver efficient patient care across various medical stakeholders. And if these are then focused on the same objective, which is to make and keep patients healthier longer, we can achieve a more positive patient experience, better therapy outcomes, and overall lower healthcare utilization and total cost of care. In the end, digital transformation can only become a reality when all participants are willing to come along the journey. This means to let go of individual interests and processes. We must rethink and question rules and processes that have existed for ages and focus on moving the patient into the center of our doing in a way that is sustainable long-term. Given that other challenges exist, such as reimbursement, cross-sectoral collaboration, and data privacy, to only name a few, it is not an easy task and possibly one of the biggest challenges we will face in the coming years. Those of you who have been through a digital transformation process or are currently in the middle of one know that the biggest barrier to successful digital transformation is not the technology or the process, it's the people. We have to find a way to take stakeholders along on the journey and equip them with the resilience, flexibility, and capability to successfully evolve. But regardless, digitalization of healthcare is inevitable and accelerated by numerous drivers. Technical solutions such as connected devices, telemedicine, digital health apps, and big data are evolving at rapid speed and will fundamentally change how we deliver care. A new generation of physicians and medical staff will actively demand innovation and digitalization and not share a lot of the reservations of the past. Patients are becoming more digital every day, and with that hold more knowledge and become more demanding. And the increasing financial pressure on our healthcare system will ultimately require us to not just think about cost cutting, but about doing things in a completely different way in order to remove waste and bureaucracy from the system. The question is, are we letting the change process guide us, or do we actively take control in driving the much needed change? We should continue to have the courage to drive change and digitalization consistently and be more bold in just getting stuff done, as we have been forced to do in the past couple of weeks. This will enable us to have a true shot at envisioning and building a transformed and better, more efficient healthcare system. Thank you for your attention and enjoy the event.
Ja, es ist meine absolute Freude, jetzt über Computer Edition for COVID-19 zu sprechen. So it's my true pleasure to talk to you about Computer Edition for COVID-19. My name is Björn Schuller. I'm with the University of Augsburg in Germany. I'm also at the Imperial College in London, where I'm Professor of Artificial Intelligence, and I'm the CSO and co-founder of Audeering, an audio intelligence company based in Munich and Berlin. So let's talk about this computer audition for COVID-19. And what is computer audition? You might have heard and likely will have heard computer vision. Now, computer vision is if you deal with computers and video. Well, similarly, of course, computer audition is computers hearing and anything that has to do with computers and audio. Now, what does that get to do with COVID-19? In fact, we can do a lot of different things with computer audition for COVID-19. We can do diagnosis. This is where we actually hear your symptoms like your coughing, sneezing, your short breathiness. We can also assess your risk by others, for example. We could monitor if somebody who is talking near to you is wearing a facial mask or not. We can also do a lot of monitoring. For example, we can monitor treatment and recovery. We can monitor the spread. Imagine, for example, in telephone networks, we could be hearing symptoms and even diagnose from the audio and then see via telephone analysis how the virus spreads. Well, we could be monitoring the social distancing and its effects. So, for example, stress detection, depression, and other things that we would be afraid of that happen in quarantine or lockdown situations. And of course, we can use computer audition for information provision. Computer audition does include speech recognition, for example, natural language processing. Hence, we could be listening to your voice and to your questions and provide you with information. We could also be gathering information from different language resources, such as the news and different tech papers, scientific papers. So you might be wondering, this sounds like sci-fi, but it isn't. We're well prepared. We've been running a challenge since 2009 at Interspeech, the largest speech processing conference, where we invited the research community to compare themselves, what they can do in terms of recognize different things from the voice and from the audio. And you can see these tasks here: risk assessment, diagnosis, and monitoring. And over the years, we have been doing a lot of things that are relevant to these. The obvious ones are, for example, breathing patterns. So we can recognize your breathing from your voice, from your audio quite reliably. We can recognize whether you're under cold or not. We can, for example, hear your health state, lung sounds, if you're wearing a facial mask or not, and sleepiness, quality, and the likes. From a sound perspective, that's quite similar. So we can hear your coughing. We can diarize speakers, so we can hear if several speakers are in the same room. So for that use case of local proximity estimation, for example, this is quite helpful. We can hear your sneezing, for example, and many other things from the voice that are useful for this. Now, if you think of monitoring 24/7, so around the clock, every day of the week, we could be hearing in, for example, from a smartphone app, and we could be monitoring histograms of your symptoms. So how do your symptoms evolve over time? Now, that way we could do a differentiation between COVID-19 and normal influenza here and a cold. And you can see this is known from many newspapers and magazines that there is quite some difference in the frequency of occurrence of different symptoms. For example, breathlessness, shortness, breathing shortness is quite common in COVID-19, but not so much in a cold. Nasal congestion, on the other hand side, is not very frequent in COVID-19 cases, but it is very much in cold. In other words, when we listen to you via your smartphone or whatever device, we could hear your symptoms and we could make a map of how often do they occur over time, and that will help us a lot in getting a clear picture what are your symptoms more related to COVID-19, influenza, or cold. A general practitioner, on the other hand side, usually has 7 minutes on average time for her patients. This differs around the world. In some countries, just half a minute. In some blessed Scandinavian countries, for example, it's almost half an hour. But still, we, when listening to you with your smartphone, would have you day and night. Now, with such monitoring, you would need time. The question is, can we even hear something directly? So from the voice, not via symptoms, but just because your voice pattern already sounds like you're COVID-19 infected. So we approached this first by looking at COVID-19 severity. We recorded with patients in Wuhan, China, different stages of their COVID-19 severity from low, medium to high. This is always the same sentence here, spoken by those who participated in Chinese. I agree to use my voice for coronavirus-related research purposes. And we had different stages of corona, high, medium, and low. Now from that we can see that we did a correct classification only from your voice in three-way severity at 68%, chance normalized. But we could even do directly a diagnosis, so COVID-19 positive or negative from the voice, and this is shockingly high in my eyes. We had 81% correct result. So it was 81% were correct in recognizing whether you're COVID-19 positive or not. We also looked at other things from those patients, at their sleep quality, at their fatigue and their anxiety. Here you're seeing the distribution of the participating patients and these different states. Now we did this with the voice again, so just listening into the voice, and you can see that besides the severity we've been looking at, we can also have a fatigue at 46%, that's not so good, and anxiety at 56%, but chance level would be 33%. So just listening into a short snippet of voice, we are able to infer way above chance level also information on that. Now there's of course a couple of challenges coming with this. Model sharing is where we need data from you to update the models on our end. We need to do this in a private way, of course. Time is a very pressing one because in the COVID-19 setting, we're very much under time pressure right about now to come up with solutions quickly. We need to collect patient data from real-world cases. There's a lot of ethical, legal, and societal impact implications. We need to do real-world processing, so we're having to fight with noises and other things. We need to do this efficient, to not dry your battery in your smartphone. And of course, we need to be trustable and provide you extra and understandable information on your diagnosis. The white boxes here indicate many other problems. I just picked the most pressing ones for you here. So how does this work? The idea is that we give you a diagnosis, but you give us the data without giving too much information away. Our app, for example, that we prepared with our company Audeering, asks you to register your user profile locally on your device, asking you some questions about your health state. Then it lets you choose how long do you want to record, for example, overnight your data, 1, 3, 6 hours. This can also be done during hospitalization when you're waiting for a GP, for example. We've done this with the Klinikum in Augsburg quite successfully. And then it gives you this kind of histogram. Here, just a short example. It collected some coughing, some sneezing, or speech. And then it asks you for 6 of your samples if you want to donate them or not. So you can always listen to them afterwards and say you donate them or not. So you're only listening into what you want to donate, and it's only coughing or sneezing sounds anonymized. Now with this app, we're currently at 83% chance normalized in recognizing those symptoms, so this works fairly well. In order to not give away your data, we can also use what we call federated machine learning, where we have your neural network model parameters, so just machine learning model parameters. We do some local training and send partial model updates back to the server, so not your audio, but just how did your neural network change for your local device. Then we send back average updates and do local fine-tuning with other users. And in an emotion recognition setting, we could prove that this works fairly well. Now, how private this is? On the voice, there's a lot of information that we have been targeting. I've been showing this at the beginning. So some of these are clearly not relevant for COVID-19, like what is your native language? How well are you proficient in your language? Do you have Parkinson's or other things? So we need to protect you. And we need to be efficient. So we need to squeeze and prune the networks. The good news is we're quite prepared to do that and have good algorithms for that. So with that, I would like to thank you for your attention and my team for helping with all the great research that I could show you today. Thank you very much.
Dear ladies and gentlemen, it is my pleasure today to introduce you to Sonas, a portable battery-powered ultrasound device developed for stroke detection and treatment monitoring. But before I introduce you to the device itself, I would like to spend a few minutes on stroke, starting with the question, what causes a stroke? In stroke, we differentiate two different kinds, hemorrhagic versus ischemic strokes. Hemorrhagic strokes are the minority, 10 to 15% of all strokes actually caused by a hemorrhage. The symptoms can be a facial droop, a weakness on one side of your body, slurred speech, and many more. The reason for a hemorrhagic stroke is a rupture of a brain artery, which then leads into bleeding into the brain tissue. A therapy for hemorrhagic stroke is either a neurosurgical intervention, which means to remove the blood pool out of the brain through a burr hole inside the skull, or simply by monitoring and waiting for a self-resorption of the bleed over time. The vast majority of all strokes are so-called ischemic strokes. They are about 85, if not more, % of all the reason for all strokes. The symptoms are very much the same like they are for hemorrhagic strokes. The pathology behind is very much different because these strokes are caused by a blockage of an intracranial vessel, an artery, by a blood clot or thrombus. The therapy of these strokes are nowadays neurointerventional procedures, means the mechanical removal of the blood clot from the vessel using catheter-based technologies. The other form of treatment is a systemic lysis, means a pharmacological way to break up the blood clots and by doing so reopen the brain vessel. Why should we care about stroke to begin with? Stroke is worldwide the second common cause of death and therefore, a huge problem not only in industrial countries. It is by far the first cause for long-term disability, way ahead of myocardial infarctions, for example. It is one of the most costly diseases in medicine we know, and it's definitely the most time-sensitive disease in medicine. And this can't be better underscored by knowing that once an ischemic stroke occurs, 2 million brain cells die every minute until treatment can be deployed. By that, with a stroke, time lost is brain lost couldn't be more true. What are the challenges we are facing in stroke nowadays? Well, it starts with the awareness, means the not recognition or wrong interpretation of stroke-like symptoms such as a facial droop. A big problem in stroke symptoms is that they're not coming along with pain sensations. That's why symptoms are, to a high extent, misinterpreted as something else but not a stroke. Location is an issue because if you are in a metropolitan area where you have a high density of not only hospitals but stroke specialized hospitals, you might be very well off and having no problems of getting the right treatment at the right time. But in rural areas, this is very much different because of the lack of the density, especially of stroke specialized centers where a quick and an immediate treatment can be provided. A third problem is transportation due to long distances, for example, or to hospital transfers. What that means is that patients who are admitted to a hospital might be not necessarily well taken care of in that primary hospital because it's not a stroke specialized center. For these, the patients have to be transferred to stroke units or comprehensive stroke centers where the proper treatment can be provided. The assumption is well supported by literature that about 30 to 40% of all stroke patients could be better treated, would have a better outcome if patients would not be transferred from one hospital to another one. So all in all, the biggest challenge is that we don't have a diagnostic device nowadays which allows us to say or to screen whether a patient might have a stroke or not. And what's so well known and established for cardio applications, for cardiac infarctions, which is the electrocardiogram, does not exist for stroke. Means the ECG for the brain is what we would like to have to improve significantly stroke care nowadays, not only for early screening, but for treatment monitoring at the bedside as well. Because of that, we've developed a device called SONUS. SONUS is an acronym which stands for stroke or not a stroke. It is a portable, battery-powered ultrasound device to aid in the unilateral as well as the bilateral assessment of cerebral blood perfusion and intracranial pressure monitoring. The device is easy to use, it is safe, it is cost efficient, and it has wireless capability. Therefore, very similar to an EKG, the Sonus device can be used wherever an EKG is being used today, such as in the pre-hospital environment, used by paramedics or emergency physicians, just to screen patients already at the site of the emergency and to direct them straight away to the comprehensive or stroke center or a stroke unit. The device can be used obviously as well in the hospital, in the emergency room, on the ward, in rehab centers, in practitioners' offices, and so forth. This short video will introduce to you how the technological concept of Sonus works, and I will leave you alone with this for about a minute.
By combining ultrasound and microbubbles, the Sonus device makes cerebral blood perfusion measurement a safe, cost-effective procedure that can be performed in virtually any location, quickly confirms suspicion of major stroke in the field or at the bedside. Initial baseline acoustic measurements are taken first, and then an IV bolus of microbubbles is administered. Microbubbles are commercially available and FDA-approved ultrasound contrast agents that consist of a gas encased by a molecular shell. Low-frequency, low-intensity sound waves, which safely penetrate bone, excite the microbubbles. The microbubbles respond by vibrating at harmonic frequencies that are detected by receivers placed on either side of the head. Through contralateral and ipsilateral data acquisition and proprietary signal processing algorithms, a bolus kinetic curve can be generated for each hemisphere of the brain. This curve is similar to kinetic curves generated using perfusion-weighted CT or MRI and can provide critical parameters such as time to peak and mean transit time that support clinical decision-making. See more Sonus data and learn about current development status by contacting us at burrellconcepts.com/contact.
Just a few more words to the technology, starting with the signal generation. Sonus transmits ultrasound in the sub-megahertz range. It alternates the transmission right versus left in a ping-pong fashion, and it applies pulse inversion in its signal generating process. On the data acquisition side, we use microbubbles, so-called ultrasound contrast agents, which are then being excited with a sub-megahertz frequency ultrasound. We have filters which are then detecting specifically the fourth, the fifth, and the sixth harmonic frequencies of these microbubbles to generate kinetic curves. And then we apply as well time boxing to separate both hemispheres, as well as getting rid of signals which are unwanted, such as in the near field. The analytic approach, we use microbubbles as acoustic traces. Normally these microbubbles are used to make better images, diagnostic images with ultrasound. We use them as acoustic traces, not to make images. We use a bolus kinetic modeling, very similar to perfusion-weighted CT or perfusion-weighted MRI, which then allows us to compute kinetic parameters such as time to peak or mean transit time. And we do this in a one-to-one comparison, right versus left hemisphere. The device has wireless capability, including secure connection to local Wi-Fi networks, accessibility of external computing devices, and we provide a cloud solution for data management. So why Sonus? Sonus is the first and only non-CT, non-MRI stroke assessment tool to instantly evaluate both hemispheric perfusion imbalances, or short HPI, and intracranial pressure, short ICP, with one and the same test. Sonus is the only system to provide a comprehensive view of brain trauma. Both HPI and ICP assessment allow for early and short/medium-term interventional therapy optimization to minimize brain damage caused by the stroke itself or the related ICP changes. Sonus is the first system to be used at the patient's bedside to assess brain perfusion and intracranial pressure. With this, I come to the end of my presentation. I thank you very much for your attention.
Thank you for inviting me to this session within the Tech Days about digital health. I want to give you some information about the protection of high-risk patients, how to protect high-risk patients efficiently during COVID-19 crisis using telemonitoring. We will look at telemonitoring and ventilation as a chance for a sustainable future value-based care concept within the German healthcare system. And this has been quite accelerated by the COVID-19 crisis. Presently, and already before the corona pandemic, we have in Germany approximately 86,000 patients in out-of-hospital facilities receiving permanent home ventilation. It looks a little bit like this. They may use it during the night or even for 24 hours a day. It depends a little bit on the personal situation of the patient. Some key points for the immediate implementation of this telemonitoring approach, this, I may say, favorable telemonitoring approach, that patients with a variety of underlying chronic conditions, such as, for example, respiratory disease, at the highest risk for severe diseases caused directly by the COVID-19. So they have to be very careful about social distancing in the current time, and by protecting this highly vulnerable patient population, the risk of infection in the physician's medical office or in the hospitals is significantly minimized for this population. By being treated and followed up by physicians, we can reduce acute admissions to hospitals. And of course, we have the continuity of delivery of care to this population as well. Complications that the patients may have or may get can be detected early as the patient still is at home, facilitating prompt intervention by the physician, by the treating physician. And this, in a sum, improves adherence and satisfaction by increasing safety for patients and their families. The long-term benefits for patients and healthcare providers, for example, is about the digital physician-patient communication by telemedical care. For example, video consultations. They facilitate early detection of complications and provide a more timely intervention. Connected care networks around the patient, for example, care nurses or home care providers and physicians. Connected care networks will bring the different healthcare teams closer together for a more aligned and coordinated patient care. Then the quality of care meets, of course, the quality of life. Use of telemonitoring and ventilation therapy has been proven to reduce hospital admissions, which is a key consideration, not just in terms of the treatment response, but the improvement of quality of life for the patient is a really relevant factor within the structure. Easy and secure data management. The data are proven and not subjective, recorded by the patient, and this provides a better system of organizing of patients and that therapy data, of course. And last but not least, a cost-effective option with the potential to reduce all cause costs is favorable for the healthcare system. COVID-19 has been an accelerator. After years of hesitations and discussions, treating physicians and relevant medical societies are now vehemently demanding the access to telemonitoring in order to be able to provide remote patient support. For example, and strongly recommended in conjunction with video consultations. the acceptance of patients to be remotely monitored has increased significantly since COVID-19, and the strong increase in demand from physicians is also leading to an increased willingness among device and healthcare providers to actively implement and use the telemonitoring platform. What we have the legal framework, we have the new digital legislation since December 19, the DVD. We have reimbursement possibilities now for digital health applications. We have electronic patient files from January 21 mandatory, and we have the e-prescription coming mid-year 21. The telematic infrastructure is already there. Video consultations by physicians are reimbursed. And of course, the increased public awareness of digital solutions is what we have, but the loop is not closed. And what we still require is to have telemonitoring as a treatment method to be incorporated into the German healthcare system performance scope. The rapid implementation of a practice-based reimbursement for remote-controlled patient intervention by physicians and home care providers is a must to fill the gap. And of course, this will end up in transformation of standard care pathways for patients with a focus on value-based integrated care, patient outcomes, and medical benefits which can be proven. Stay healthy and